Good afternoon, everyone. My name is Dr. Minakshi, and I'm going to present a case report of recurrent idiopathic orbital inflammatory disease. There are no financial disclosures about this presentation. First, I would like to give a brief introduction. It is a benign non-infectious inflammation of the orbital structures without a known local or systemic cause. It's also known as non-specific orbital inflammation, orbital pseudotumor, or idiopathic inflammatory orbital disease. It's the third most common orbital disease seen in adults. It can be localized or diffuse. Commonly involves the orbital fat, lacrimal gland, as well as extraocular muscles. So a 35-year-old female patient presented to us with swelling in her left eye since 4 years. The swelling had always been in the left eye only and involved the upper part of the upper eyelid and sometimes even the whole upper lid. It was associated with pain and redness in the eye, and as per the patient, her vision was like never affected. The swelling subsided by the treatment but reoccurs after a few months of stopping treatment. She was a non-case of hypothyroidism and was on treatment and was well controlled by 25 microgram of thyroxine. And as per the old records available, she has taken some oral steroids for her condition. On examination, her visual acuity in both the eye was best corrected distance visual acuity was 6/6, and anterior segment of the right eye was within normal limit. This is her left eye. As you can see in the central picture, the left eye was swollen more on the outer portion of the eye and giving an S-shaped ptosis. And the temporal congestion, conjunctival congestion was also seen. The ocular movements, however, were free, painless, and full. The dilated fundus examination of both the eye was within normal limit. There was no disc edema or any other pathology appreciated. So we thought on lines of orbital cellulitis, so started her on some systemic antibiotics, amoxicillin and clavulanic acid, 625 mg TDS, along with some anti-inflammatory and painkillers, along with topical weak steroids and antibiotics. And in the meantime, we also ordered some systemic investigations for her. Her complete blood count with ESR count came out normal. Thyroid profile was well controlled. We also ordered blood sugar and renal function test. Her old ultrasound B scan orbit, which was done like 1 month back, was within normal limit. Definitely there was swelling of soft tissue in the superolateral compartment of the orbit. However, there was no involvement of the ocular muscles mentioned. Her MRI brain advice came out, showed some like non-specific demyelinating changes in the parietal region, and soft tissue thickening and inflammatory changes were seen involving the left superolateral aspect in extracorneal compartment in the region of lacrimal gland. The lacrimal gland was inseparable from the swelling, and the swelling extended to left preseptal region and shows loss of fat plane with adjacent part of left lateral rectus. Bilateral extraocular muscles were normal in size and signal intensity. So we were confused because the whole these pictures were pointing towards the pseudotumor, but still because the patient had a history of 4 years and again she was complaining that as soon as she stops the treatment, the swelling comes back. So we couldn't rule out the lymphoproliferative disorder. So we ordered a FNAC for her, which shows non-specific polymorphic nuclear cells suggestive of inflammatory pathology. No abnormal malignant cells were seen. So we started her on oral steroids 40 milligram and along with the PPI and along the topical treatment we started continued. This is her eye 4 weeks after the treatment. The swelling completely reduced. The conjunctival congestion was gone, and she was feeling much better symptomatically. Coming on to the discussion part. So inflammatory orbital eye disease is not like a rare disease. It's very common, and the commonest presentation of this disease is abrupt painful swelling of the lid or lacrimal gland area, and patient can even have proptosis. Mainly it's unilateral, but bilateral cases are seen in pediatric patients. So for such patients, basically why I'm presenting this is case to point out the important things that should be done while examination. Like you should always examine the lid, because sometimes the main differential diagnosis of this disease is thyroid eye disease, which can lead to certain restricted movements. We should always check the ocular movements, because thyroid and this disease both can involve extraocular muscles. We should always dilate the patient, because as the name suggests, it's an inflammatory eye disease. It can even sometimes lead to optic disc edema. So the various differentials of this disease is orbital cellulitis, thyroid eye disease, sarcoidosis, and lymphoproliferative disease.